So I'll conclude today's session by talking about another topic which is very interesting to me, being ACL injury prevention, and talking about the evidence there is currently in the literature to justify doing ACL injury prevention. Now, the current literature is replete with evidence which suggests that female athletes are 4 to 6 times more likely to suffer an ACL injury than their male counterparts, which really make them a perfect cohort to investigate the efficacy of ACL injury prevention. So as a result, we're really going to start by focusing on young female athletes. Now, the literature also has very clearly identified 4 different theories about why female athletes may be at higher risk, being structural and anatomic, hormonal, biomechanical, or neuromuscular differences. Now, because biomechanical and neuromuscular differences are the ones that are modifiable, again, we're going to focus on these 2 parameters. So now the million-dollar question is, why are female athletes more likely or more vulnerable to ACL injury? Why would this young athlete who's done this maneuver many, many times in her career, why this time does she go into this at-risk position and ultimately suffer an ACL injury? And I'll ask you to think about this picture in your mind as we start to talk about the mechanism behind ACL injury. So when we ask that question, why is the female ACL more vulnerable, we must examine the injury mechanism first. And the literature has begun to identify this position of knee abduction, low knee flexion, landing in a single leg, and landing with the foot outside or away from the center of mass as the likely mechanism about why female athletes are more likely to suffer ACL injuries. Some early evidence over 10 years ago was outlined by Malinczak when they looked at a comparison of kinematics and EMG data in men and women during running and cutting maneuvers, so during high-risk maneuvers. And what their results suggested was that women had decreased knee flexion angles, increased knee valgus, greater quad activation, and decreased hamstring activation. All those factors which were very nicely displayed by our young female athlete who tore her ACL a few slides ago. More recently, in a study that was conducted in our lab in 2005, we did an analysis of over 200 young female athletes prior to their participation in a soccer season, in a basketball season. And we did biomechanical measures of neuromuscular control and valgus knee loading. And then following their evaluation, they went out and participated in sports. 9 of those female athletes went on to tear their ACL. And from that, we were able to create a predictive model to determine what makes young female athletes at high risk for ACL injury. Some of the most interesting findings were side-to-side differences in vertical ground reaction force. So again, as we talked about with our second ACL injury a few hours ago, we see side-to-side differences in vertical ground reaction. In addition, we see a much faster loading rate. So we see higher forces being imposed on the knee at a faster rate than the young female athletes that went on to tear their ACL. Here we see a scatter diagram looking at knee valgus or knee abduction. And you'll notice if you look at it there's a group that seems to be living down here, which is a more knee abducted position, and a group that seems to be living up here, which is a more knee adducted position. And each point represents the 205 young female athletes. The red X's, which are demonstrated here, represent the 9 young female athletes that went on to tear their ACL. So you can see living in with a more knee abducted position certainly is a higher risk position. This one athlete that's down here, certainly we would consider a very high risk. I would hate to be this young athlete right here. Here we see a representation of the 9 athletes who injured their ACL versus the remaining of the 205 who did not tear their ACL. You'll notice that knee valgus position at initial contact was much greater in the ACL injured population, and also there was a decreased knee flexion angle similar to what Malinczak noted in a sagittal plane when looking at the group that went on to tear their ACL. So these findings have been validated by future research beyond our study from 2005, and in studies between the years of 04 and 06, video analysis has been used to look at 2-dimensional analysis of young athletes tearing their ACL. And what they did was looking from different angles. They had a panel of experts come in and try to identify the position the knee was in when the ACL actually tore. And what these panel of experts suggested was there was a valgus collapse position, which occurred more frequently in females than males. Oftentimes, the athletes landed in a single leg position. The foot may have been planted away from the trunk, or the trunk was outside of the base of support. There was a decreased knee flexion angle, and oftentimes there was an unanticipated perturbation of the trunk. In these cases, we can appreciate that this is a very nice descriptor of the mechanism which we've seen outlined in the previous few slides. And finally, a very important study which was done in 2007 by Zaslak et al. Looks at the importance of the contribution of the trunk. And for years, I think we ignored the trunk when we looked at the ACL injury mechanism in young female athletes. But with this study and others since that time, we've been able to appreciate the fact that the trunk plays a vital role in the position of the extremity and the stress that's placed on the lower extremity. Specifically, in Zazelak studies from '07, they did a study where they stabilized the lower extremity and they looked at the core proprioception they looked at proprioceptive measures of the trunk and the core. And what they noted was that when they followed these athletes for 3 years, the young female athletes who had the worst perception of where their trunk was in space, or had the worst proprioceptive measures, had the highest risk of ACL injury, and that in fact predicted ACL injury. So in addition to the valgus knee position of the knee and landing on a single limb, we see that the position of the trunk increases the stress that's placed on the lower extremity. So now we have a better idea of what the mechanism is, and probably have a little bit closer idea as to why the female ACL may be more vulnerable to injury. So now when we start to talk about prevention, the next step in this phase is to take those mechanisms which we just identified and try to identify parallel neuromuscular imbalances. And what I mean by that is looking at from a neuromuscular perspective, what may be existing in these young female athletes that can address some of these high-risk positions or high-risk mechanisms. And when we talk about knee abduction, we'll talk about ligament dominance. When we talk about a decreased knee flexion angle, we'll talk about quadricep dominance. And finally, when we talk about that single limb landing position and the importance of the trunk, we'll talk about side-to-side differences or leg dominance as well. So what is ligament dominance? And it's been discussed in the literature over the last probably 10 years that it's defined as the lack of dynamic muscular control in the medial lateral direction, resulting in increased valgus stress on the ligaments. And you can appreciate as a young female athlete lands, she tends to use her knee more as a ball in a socket, as opposed to our young male athlete who tends to use his knee more as a hinge joint. Again, female athlete, we see that valgus knee position. We see the joint acting more as a ball and socket. Then she's relying more on our ligaments to control movement, as opposed to a young male athlete who uses his knee much more like a hinge and uses the neuromuscular contribution of his lower extremity to control and dampen forces at the knee. Quadricep dominance has been defined as a preferential activation of knee extensors over knee flexors with athletic maneuvers. And this has been defined since 1996 when Laura Houston and Ed Voitis first outlined it, and been reiterated over the years in the literature. And finally, leg dominance has been defined as a muscular imbalance, a recruitment imbalance. It's that preferential activation. In my presentation earlier today, when I talked about return to sport after ACL reconstruction, we talked a lot about limb asymmetry and this concept that some athletes tend to favor one limb over the other. And if in fact they are favoring that limb, they're going to be placing higher forces and increasing risk on that limb as well. So now that we've identified the mechanism, we've identified parallel neuromuscular imbalances, now we must address these mechanisms. And what we'll do from a neuromuscular re-education standpoint, we're going to address that through biomechanics and technique training, trying to address altered quad ham ratios, looking at improving balance and symmetry, and then working on that core stability as well. But we shouldn't just apply these principles indiscriminately. We must first look at the literature and see what the most appropriate application of these interventions is to decrease risk for ACL injury. So where do we start? Well, if we look into the literature, if we do a PubMed search on anterior cruciate ligament, you'll know that there's over 8,000 citations currently in the literature, far too much for any one of us as clinicians to review. If we look at anterior cruciate ligament in addition to prevention, still there's over 400 citations in the literature. So again, far too many things for us as clinicians to look at on a day-to-day basis. So let's go first to the highest level of evidence that's currently available, being a meta-analysis. And there was actually 2 studies that were published, one in a journal called The Knee, and then this in AJSM, which looks at anterior cruciate ligament injuries in female athletes, and it looks at a meta-analysis of the current literature of what it's saying regarding ACL injury prevention in female athletes. So all of these studies were designed to decrease knee and ACL injury in risk. And so again, it's a systematic review, and within the context of the systematic review, it yielded 6 published studies, all of which looked at trying to reduce ACL injuries in female athletes, and also had some common training component as well. So it looked to have a targeted intervention, a targeted neuromuscular training component to try to reduce ACL injury risk in female athletes. The key terms that these authors used were knee injury and sports injury, intervention and control. It was a randomized controlled trial or a prospective cohort study, which was included. And finally, they had to examine some type of neuromuscular intervention. Again, 5 studies were identified in the literature at this time, and 5 of those 6 studies concluded that neuromuscular training had the potential to decrease knee injuries in general and also decrease ACL injuries in female athletes. Here we see a forest plot representing their findings. And again, when they did a meta-analysis, when they pooled their data, they in fact did find that the data suggested that there was a favorable outcome in the ability to reduce ACL injury in female athletes. So let's look at each of those 6 studies independently and see what they've shown us to see if there's any commonality between those 6 studies. We're starting to appreciate that, yes, neuromuscular interventions can decrease ACL injuries in female athletes and healthy female athletes. Now we have to identify what is incorporated in each of those interventions. So the first study was a study by Hewitt et al. Was published in AJSM in 1999. He had a prospective cohort design, and he recruited 30 high school teams of female athletes and 13 male high school teams as well. And they separated them into 3 groups. One was an intervention group of female athletes, one was a control group of female athletes, and one group of male athletes that served as the control as well. The intervention was a very rigorous program. It was a preseason training program. It incorporated neuromuscular intervention, plyometrics, but it lasted over 75 minutes, so a very intense program that needed to be done 3 times a week for 6 weeks. These authors did note, though, there was a 72% reduction in the rate of non-contact ACL injuries. In 2000, Hite published a study in a very small cohort. He only looked at 42 subjects of female soccer players, and he looked at an intervention of only treadmill speed training and foot agility training. And what Hite et al. Noted was their intervention was fairly intense, twice a week for 7 weeks, and it took about an hour. They also noted a reduction in injuries from 33% to 14%. However, their interventions did not have an effect on ACL injury rate. So we can start to think about what some of the differences are between these studies that show a reduction in ACL injury rate versus others which did not. Soderman in 2000 published a very strong study design, a randomized controlled trial of over 140 professional female soccer players. Interestingly, his intervention was only a home exercise program and really didn't comment on compliance within the interventions. The intervention was only balance training. It did not incorporate plyometrics or strength training or other interventions. But again, he recommended 3 to 7 times a week in season as well. So it was a preseason and in-season training program. Interestingly, Soderman noted no differences in traumatic injuries or ACL injuries. Mickelbust in 2003 published a very nice article, a prospective cohort design, a very large cohort, over 2,600 female team handball players over a 3-year span. And what his intervention included was balance training, plyometric training, jumping and landing skills, and other drills as well. His program, interestingly, was a hybrid program. There was a preseason intervention that was done 3 times a week for 7 weeks, but then there was a program that continued once a week during the season to continue to expose the athletes to some type of injury prevention during the season. Their outcome was significant to reduce ACL injuries in their cohorts. Mandelbaum in 2004 published a controlled cohort study with over 5,700 athletes. So again, a very large sample size of young female soccer players between the ages of 14 and 18. His program was strictly an in-season training program, though. Only neuromuscular training that could be done the 20 minutes before the soccer practice each day. It was really designed to be a replacement for the common warm-ups, but did not include any preseason training. These authors noted a 74 to 88% reduction in ACL injuries compared to controls. Peterson in 2005 published a prospective case control study as well, looking at 276 female handball players. Their program incorporated both balance training and plyometrics, and also was a hybrid program, both a preseason and in-season program. Interestingly, these authors noted there was an 80% reduction in ACL injury risk. However, these findings were not significant, suggesting that the sample size of 276 subjects was likely not sufficient to meet their power. It was underpowered, the study. So therefore, you can appreciate that these type of studies really need large sample size, 2,600, 5,700 participants, to be adequately powered to make suggestions of significant interventions. And finally, Wetterkop in 1999 published a randomized controlled trial of 237 female handball players. The intervention, again, was balance training and whole body warm-up. It was done as a pre-participation or a prior to practice program, and they did see a significant reduction in overall injuries rates. So here we see a graph, again, representing the potential reduction in injuries that we see in the 6 studies, with only one really not demonstrating any efficacious outcome with reducing injury rates. And again, we see our forest plot again, suggesting that when we pull the data, we see an improvement or a favorable effect on reducing injury rates as a result of the interventions. So theoretically, if we look at it from a neuromuscular perspective and try to look at it from a mechanistic perspective in that sense, if neuromuscular training can increase neuromuscular control of the joint, if we can increase our ability to control that joint, and we decrease knee and ACL injury risk, then truly the mechanisms which underlie increased risk may in fact be neuromuscular in nature. So when we start to break down the programs now, we start to try to look at evidence for different types of interventions. Let's first look at biomechanical and injury prevention effects on these interventions. In summary, there appears to be a measurable effect of neuromuscular training interventions on the knee. 5 out of the 6 studies reduced general knee injury risks. 4 out of the 6 studies reduced knee injury, and 3 out of the 6 reduced ACL injury. So now we must ask the question, what is similar among these programs? So in an attempt to try to find the common thread that lives between the studies that were efficacious in reducing knee and ACL injury risk, let's break down their programs into these 6 components, being landing training, balance training, plyometric training, technique training, core stability training, and strength training. So let's first look at landing and balance components. So the effects of these three out of the 6 interventions reduced ACL injury rates. So of the 6 studies, 3 reduced ACL injury rates and appeared to be similar, arising from these same components of performance enhancement and physical rehabilitation of athletes. Plyometric training and biomechanical analysis and technique training were common components of all 3 studies that effectively reduced ACL injury. So we're starting to see there may be a common thread. Maybe plyometrics and technique training are an important intervention, but let's look more further. So the 3 studies that reduced ACL injury risk did incorporate plyometrics into their training programs. And conversely, all 3 studies that did not incorporate plyometrics did not, in fact, reduce ACL injury risks. Now, what positive impact do plyometrics have? Now, plyometric components, as we know, train the muscle, connective tissue, and nervous system. And it focuses, and probably most importantly, it gives us an opportunity to focus on proper technique and body mechanics. So again, if we think back to our mechanisms of our trunk being outside of our base of support, of our knee being out of alignment when we landed, all increasing our risk for ACL injury, utilizing plyometrics and focusing on technique within that program may give us the opportunity to reduce ACL injury risk, as evidenced by these studies. These training interventions that incorporate plyometrics, again, look to try to provide safe levels of varus and valgus and then try to induce more muscular contributions or neuromuscular adaptations. Again, trying to reduce the quad dominance or reduce the ligament dominance in these female athletes and try to improve the contributions of our muscles to control movement. The studies by Hewitt, Mandelbaum, and Michaelbos all incorporated technique analysis, so they all provided feedback to the training. It was either another coach or another player, but there was some type of technique analysis and feedback that was given, and all 3 of those were efficacious in reducing ACL injury risks. Of the 3 non-effective studies, none of those incorporated landing and cutting techniques, and none of them found to reduce ACL injury risks. Well, let's talk a little bit about balance, because the intervention of the 2 balance studies only were not effective. So the studies that only did balance interventions did not show reduction in ACL injury risks. The Wetterkrupp study was effective in reducing overall injury risk, but not knee or ACL injuries. So this would suggest that in female athletes at least, balance training alone may not be sufficient to produce significant knee or ACL injury prevention effects. Interestingly, though, if we look historically into the literature about ACL injury prevention, one of the first studies that was published in the mid-90s by Carafa looked at male soccer players in the Italian soccer leagues, and they only provided a balance training intervention, and they did see a reduction in ACL injury risk. This conflicting data between genders suggests that potentially maybe we need different types of interventions or more gender-specific interventions to reduce ACL injury risks. But what about balance and core stability? Now, the studies by Hewitt and Mandelbaum did incorporate single-leg landing and stability training, and they primarily did that through the utilization of hop and hold positions or a decelerated landing. So again, we see a position where athletes were asked to hop and hold their position to try to decrease or to use their trunk to control. Oftentimes, single limb stability was gained with this balanced type of training. And again, the findings did support this type of intervention to decrease ACL injury risks. Well, what about strength training? Because prior literature has suggested that strength is an important component to decrease ACL injury risk, when in fact, the studies by Hewitt and Mandelbaum did incorporate some strength training in their interventions, which were both efficacious in reducing ACL injury in female athletes. However, other studies which were also efficacious, such as the one by Mickelbust, did not have a strength training component. So there does seem to be some mixed evidence of the need to do strength training to actually reduce ACL injury risk in female athletes. So finally, I think it's important to talk a little bit about those things which were not discussed in this literature, which I would like to talk about, I like to term the intangibles. So for instance, these studies did have a tremendous amount of variability in the intensity of their interventions. Some were only preseason programs where they had very intense 60 to 75-minute training programs, only in a preseason fashion. Others were very brief in-season programs, and then still others represented hybrid programs. What's the most efficacious intervention? We can't really glean that from this data. What about the intensity and frequency of the program? And then finally, will these type of programs, which have been seen to be efficacious in female athletes, will they ultimately be efficacious for males as well? Those questions we truly don't have the answer to today. So as we start to summarize, these studies did provide good but not unequivocal evidence that neuromuscular intervention training is likely to be an effective solution to decrease gender inequity in ACL injuries. The selective combination of neuromuscular training components may create further additive effects and further reduce this risk of ACL injuries. But certainly, additional research is needed to really design the best injury prevention program for these young female athletes and to determine the answers to some of those intangible questions. What's the best type of program? What's the best intervention? And will this intervention work for both males and females? So ultimately, what we'd like to do is create a system where we can predict high-risk individuals. If we have a group of young female or male athletes, can we create a system where we can screen these athletes and determine who's at high risk? And ultimately, when we determine the reasons they're at high risk and who, in fact, is at high risk, can we develop interventions and can we train these athletes to try to address these neuromuscular imbalances and these neuromuscular mechanisms, which we've seen now increase our risk of injury, and then ultimately try to prevent these ACL injuries, which we see in young female athletes. I'd like to acknowledge those people, responsible for the majority of this work in our laboratory, Dr. Tim Hewitt, Kevin Ford, and Greg Meyer, and the rest of those individuals at the Sports Medicine Center at Children's Hospital. And I'd like to thank you all for your kind attention on my presentations today. Thank you very much.